going to shift gears now and talk about cardiomyopathy in the perioperative period. Nothing to disclose. And we're going to use this case. It's a real case. I know sometimes you come to meetings and it's nice to construct a case. This is actually a real case. A 65-year-old lady who came to the ICU after having a femdistal done for an ischemic lower extremity. Her hospitalization actually started at an outside hospital where she went about 36 hours before this surgery, complaining of some pain in her leg and some slight coolness. They put her on some heparin. The leg actually got worse over a period of time. They didn't have an invasive radiology or vascular surgeon at that particular institution, so she got transferred. She went to invasive radiology. They were not able to get her leg open as it was worsening, so she was posted to go to the operating room. As it mentions here, her discharge summary tells us that when she got to that other hospital, she had a blood pressure of 215 over 115, that they had done an echo when her EF was 20%. And so anesthesia saw her preoperatively, saw that ejection fraction of 20%, and said, okay, so we're going to do this lady with a pulmonary artery catheter. This particular case is about 10 years old now, but a real case. And so they put in a swan in the operating room before inducing anesthesia, and her cardiac output, not cardiac index, her cardiac output was 2. They gave her 500 cc's of fluid, and her cardiac output was 2, so she did not appear to them to be fluid responsive. So they put her on an epi-drip. Her cardiac output was 2. They induced anesthesia, kept her at a cardiac output of 2 the whole case. She arrived in the ICU acidotic, lactemic, not making any urine, very mottled, and within 45 minutes of arriving, her family came in and said, you know, she almost didn't agree to go to surgery. If this is what the outcome is going to be, why don't we just stop all therapy right now and let her pass? So let's talk about this case and what actually is going on. We're obviously talking cardiomyopathy, so this has some connection to congestive heart failure. So we're going to start with this idea of what does it mean to you, and then we'll progress from what it might mean to you with some background foundational information to does it really make a difference to know what it means and how we're describing it. So to you, I think to many people, it means pulmonary edema. And this slide is just trying to make you think about that and make you realize that some patients get venous congestion and alveolar fluid and get what we think of as RALs and pulmonary edema, but other patients actually get pleural effusions associated with altered pump function, and some patients get both. It could be confused. I've seen several cases now in my career where the chart is labeled congestive heart failure, but the person had some episode of acute renal failure related to some problem and was in pulmonary edema related to an inability to deal with volume on board. Once dialyzed, was not in pulmonary edema anymore and never had any evidence of any cardiac dysfunction. These were really volume overload cases related to end organ problems. But now the chart says CHF, and so we all dutifully do what? Every time they're now seen, we write history of CHF because somebody else wrote it in the chart. And is it always that what we think of in congestive heart failure, which is that somehow with inability to squeeze, you got this baggy, saggy sort of heart that can't really move fluid forward, so you get this backup of fluid sort of model into the lung. That's what we commonly think of. That would be reduced function. Is it always related to reduced function? So first, just as background, let's make it clear that about 50% of patients have reduced function when they have congestive heart failure, but about half don't. Now, you might see in the literature 30%, and you might see in the literature 60%. I've chosen 50 because if you take all comers, that's really true. And it really depends, are you talking men or women, and are you talking 40-year-olds or greater than 80-year-olds? And every group has a slightly different balance between these two. But for all comers, it's about a 50-50 issue. Now, we could be, when we think about what's causing this problem, whatever that problem is with their heart, we could divide them up and begin trying to discuss them today into sort of these categories. I'm not going to do that. I don't think it offers us any good physiologic understanding of what's occurring. And hopefully, if we can understand their physiology better, we can think better about better treatment strategies as well. Or I could really drive you crazy, and we could describe them like this slide, which is only half of the etiologic diagnoses. Here's the other half. And we could spend probably the next 3 days trying to go item by item. And it is important because slightly different etiologies may have certain implications of care. suffice it to say I'm not going to do that. In a few minutes I'll be clear. If it's not clear to you already, I'm going to be a lumper and divide these into only two categories for sake of trying to discuss them. So all I've tried to do now is shock you a little bit for some people in the audience to get you to think that maybe congestive heart failure isn't what we always think it is, that it's a bad label unto itself. And I'll try to stress that in this next part a little bit. It's a bad label because are the outcomes different? If they are, then we better think more than just CHF. We better be thinking about function, not CHF. And does it make a difference in treatment? That's going to get us back to the case that I showed you. So this slide is merely trying to show you that if you take patients and you lump them into two broad categories, they have a problem with squeeze, they have reduced function, also called systolic dysfunction, then they have a very different outcome over time compared to those who have not a problem with squeeze, but a problem with relaxation, a diastolic dysfunction. If you measure their function, it's preserved. So all those words mean the same thing. Preserved function, diastolic dysfunction, relaxation problems are all diastolic, and systolic and squeeze and dilated are all in the other category of reduced function, okay? So it does make a difference in these patients, at least long term. You see those curves deviate even in the first year, so it even makes a difference in them in the short term, that we really understand what we're talking about. Now, most people, again, think that systolic is the most common, and so this slide is merely trying to, again, give you that information that might surprise some. Especially people believe that if they have vascular disease, they must have had this sort of multi-infarct, multi-ischemic cardiomyopathy, and so their function can't be as good. And here's a study of over 300 patients where they routinely did an echo to try to understand what their function really was, and look what you found. 43% actually had isolated diastolic dysfunction, so preserved function, but with evidence of poor relaxation issues. Only 8% actually had that baggy, saggy, systolic, reduced function heart. A number of the patients had congestive heart failure post-op. In this case, that means things like they heard rouse. We're all not very good with our ears. We know that from the literature, but they thought they heard rouse, or they thought they saw venous congestion on chest x-ray. So soft calls for what you might consider congestive heart failure, but labeled that way in the study. And what was most predictive was not the group that had squeeze problems. It was the group that had relaxation problems. So it sort of shocks us that maybe this is an important issue that we need to really figure out what the difference is between these two conditions. So yesterday I heard Dr. Faraday say, so here's the coagulation system cascade, and I'm sure everybody's getting queasy, so I'll borrow. Here is the volume pressure curve for either ventricle. We'll choose the left ventricle. We're going to go back to the very basics of physiology to try to walk you forward pretty quickly. So what's on this curve? Down here, if this was the left ventricle, the mitral valve would open. And then across that bottom, you would have diastolic filling, right? Then you have isovolumetric contraction, and then you have left ventricle, the aortic valve opens, you get ejection, and then you're going to get the downside, the isovolumetric relaxation. Next beat of the heart, the cycle goes again, and if you did these in a cath lab, you would layer hundreds, if not thousands of these on top of each other, cycle after cycle. I drew this by hand. I am a no-CAD artist. The ejection phase doesn't really look quite like that. I'm just trying to give you a stylized interpretation of one beat of the heart. Please note immediately that in diastole, during filling across the bottom of that curve, volume is changing in the ventricle, right? The valve opens, there's passive flow from the atria into the ventricle, and then the atria is going to contract. There's active flow. But notice the volume changes pretty significantly, but the pressure barely changes. So there's a disconnect between volume and pressure. Please notice the same disconnect on the top, ejection. And please notice that on the two isovolumetric sides, volume doesn't change, isovolumetric, pressure changes a lot. So using pressure at any time to understand volume in the heart is really not a good idea. All of those old formulas out of Swan catheters are going to be misleading, and I'll show you a little bit of data. There's a disconnect between those two numbers, and the worse your heart functions, the more the disconnect exists. So if we look again at this curve and you think about echo data you might get, or resting gated heart scan data. At end diastole, you have that volume in the heart. After the heart is ejected, you're going to have an in-systolic volume, and the difference between those two, the diameter of the graph, the curve, is actually the stroke volume. So let's just remind ourselves of what ejection fraction really is. So that stroke volume is just mathematically calculated, and then EF is that stroke volume over the end-diastolic volume. So it's how much you squeezed out over where you started. Okay, simple sort of concept. So let's deviate for a second and ask ourselves a hypothetical theoretic question. For this person, could you see a low EF but put a swan in and get a normal cardiac output? Those who are looking down at the information know. For those who are not, let's really think about that a second. If the EF told us that there's a problem, could the heart really work normally? Let's assume both are accurate. And the answer to that is yes. Our brain immediately wants to answer no. There's two answers for yes and why it's true, and in fact it can be very true. The first answer is because they're different formulas, right? So they both have stroke volume in them, but one is stroke volume as a percentage, a number over the end-diastolic volume, and the other is stroke volume times heart rate. So you might say, well, I'll just have my patient be tachycardic. If their stroke volume is not too unreasonable and they're tachycardic, I get a good cardiac output. But right, the faster your heart goes, the less time you're in diastole. The less time you're in diastole, the less filling, so you start to compromise stroke volume. So you get there mathematically by making heart rate fast. You can't get there clinically by making heart rate fast because you compromise the first number to make the second number go up. Okay, so it's really the other reason that's the real reason, and that's depicted here, which is that that same stroke volume of those two size ventricles is the same. But the stroke volume, what's ejected from a small ventricle is 50% of that ventricle, and what's ejected from a large ventricle is 30% of that ventricle, but the actual volume is identical. So at the same heart rate, they would have the same cardiac output. So EF is an artificial concept. Your organs don't care what your ejection fraction is. They do not care. God did not make us, or however you want to look at our organ blood flow and why we exist, doesn't exist because of EF. What our organs care about are flow and perfusion pressure. Okay? EF is a term we've come up with, and unfortunately it has a huge amount of value for us, but unfortunately people have translated it into giving us the total answer as to whether the heart works correct or not. Remember, your heart will adjust over time to do what? If your body cares about flow, and it only has two ways to control flow, heart rate and stroke volume, your heart is going to adjust itself in an attempt to do what? Keep stroke volume normal. So in pressure problems, it hypertrophies, and in volume problems, it dilates. The whole goal of those changes that the heart is doing is to keep stroke volume normal so it can keep flow as close to normal as possible, so that if you get acutely ill or you got to run down the block, then you can use your heart rate to adjust quickly and come back, but you're keeping your flow pretty normal so your organs stay perfused. Okay? So your goal is that your EF is going to be all over the place. It's really what your flow is that's important, and don't make that mistake of thinking that they're the same thing, because they're not. So we're going to start with the side of this that people seem to just have more difficulty understanding, the diastolic dysfunction side. I'll be much briefer on the systolic dysfunction side than I will be on this side, because again, I think this one's the one that confuses people. So here's that normal curve. I would ask you, where do you think it goes if there were hypertrophy involved? And it goes up and to the right. Some people think it just goes up, that there's higher pressures at the same volume, but it actually goes up and to the right. So there's higher pressures at lower volume. Is this just an artificial idea, or does this really happen? So here's a study that actually took patients to the cath lab and looked. Note that in the controls at end diastole, they had about 115 cc's of blood calculated in their ventricle, whereas those who had diastolic dysfunction had about 103. 12 mils different. Yeah, it's about 10%. But 12 mils different between the two groups. But minimum ventricular pressure and end diastolic pressure, something we think we measure with an occlusion catheter, was 8 in those that had 115 cc's and 25 in those that had 103. So they had less by volume by 10% and 3 times the end diastolic pressure. So if you were measuring them and you found a wedge, a pulmonary artery occlusion pressure at 22, you might think your patient's in pulmonary edema, when in fact they're normally 25, they may be walking around volume depleted. So there's a disconnect between pressure and volume, a real disease that happens, lower volumes, higher pressures, okay? I saw Lenny throw some slides in, so this one is intended also to sort of make a point. What I'm trying to do is get you to just have a visual image for those who have difficulty understanding this disorder, that diastolic dysfunction is the inability to relax. These guys can't get their arms to really come all the way down. That's what we think of, at least. And so that's that image of that hypertrophied muscle that's just not going to relax for you. And if we could do something that would allow it to relax, then we could alter that pressure-volume relationship, okay? So that's where we're going with the next bit. How do you diagnose it? Lots of different ways. Do they have a heave? Do they have LVH on chest, on EKG? Do you have other data? The most common is by echo, and there are now very specific echo criteria for the worst of this end, the real severe diastolic dysfunction end of this. But these other sorts of things of LV hypertrophy and cavity obliteration should trigger in your mind that the patient may very well have some degree diastolic dysfunction, or maybe I should be managing them as though they have diastolic dysfunction because they're going to do better with that management style compared to some other management approach. I'll explain E to A shift for those who are not aware on this slide. So I mentioned, right, your atria, that valve opens and the atria dump blood out passively, and then the atria contracts and you get an active component. So if you look at the Doppler signal during the passive, lots of blood, the majority of the blood leaves the atria. And so you get a large Doppler signal that occurs. There's less blood left during contraction, so the Doppler signal is lower. First component, the E, the second component, the A. If the ventricle's stiff, when the valve opens, not so much blood flows out passively. So the E component falls. There's more blood left behind for that atrial component, the atrial kick component, and it's squeezing into a higher pressure volume ventricle, so the A component, the Doppler signal goes up because of that resistance to flow, plus now a greater volume. So the E to A shifts on the Doppler signal. That's how simple that is. But we could identify this in many other ways. Here's an example, detail not necessary. The slope of filling changes if you're doing color Doppler. If you took the person to a cath lab and you put a catheter in, the first part of the curve is 0 to 40 is the scale. The second part is 0 to 200. That's done to blow up the graft so that you can see subtle changes. And the diastolic component in a normal ventricle is pretty flat. You can see there's something going on in diastole here. So there's really a change that is occurring in these patients and their inability to relax and accept volume. I said we're lumping. We didn't want to use those two sort of pink slides of 1,000 different diagnoses. So here's the core differential for the majority of these patients. I've given you the full possible differential. So these things that produce hypertrophy like chronic hypertension or hypertrophic cardiomyopathy, the aortic stenosis, acute ischemia, the segments that are acutely ischemic actually are rigid and can't relax. Ultimately, this may affect the systolic dysfunction of the total ventricle, but those segments actually have relaxation problems to them. And then very elevated PEEP can do what? Transmit that pressure through principally the ventilatory management over to the RV. The RV is thinner walled than the LV in most patients. So then what happens? The septa bows over into the LV. And by that septa bowing into the LV, you take that ventricle and you make it now, you alter its volume pressure relationship. And the same thing can happen in tamponade. Pressure around the sac of the heart, transmitted primarily into the RV in most patients, causing septal shift, compromise to the left ventricular side, and so it will have some aspect of a diastolic-like dysfunctional state. So let's think about now, if we understand how to diagnose them and that this exists for real, how would we compare these patients, which will lead us into how to treat these patients, and then, as I said, we'll move on to systolic. The normal is just trying to give you numbers that are easy to calculate. If it was normal, it'd be about a 50 kilo person. I say that because normal stroke volume is about 1 cc per kilo. So here's just some normal numbers. At the end of diastole, let's say the heart is about 100. After you squeeze, it's about 50 that's left behind. That means 50% was ejected. And we say an end diastolic pressure of up to about 10 is normal. So just giving you some numbers for reference sake. On the diastolic side, you should already be able to predict. We said that there's going to be what? There's going to be less volume at end diastole, meaning less volume at end systole. The stroke volume will be the same. Ejection fraction now is stroke volume over a smaller starting volume, so the percentage is going to increase, right? And pressure will be elevated. So straightforward, just what we would have learned from looking back at the original curves, okay? Notice again, same cardiac output for these two states despite two completely different ejection fractions and two very different pulmonary artery occlusion pressures, mirroring the study that I showed you from a particular cath lab study, okay? So that's the concept that you have. Now, how do you think about treating patients? So I picked the normal category and just gave normal answers. I will admit that euvolemia is something we could probably spend the whole 4 or 5 days discussing and arguing and trying to figure out exactly how to monitor and measure euvolemia. But suffice it to say that in the diastolic dysfunction patient, think about what we've already said. They're squeezing almost everything out to begin with. If you run them dry, they don't have any reservoir left to squeeze out. They were almost emptied when they were full, when they were normal. So what's going to happen if you run them dry? They don't have any more to give, so you start to compromise stroke volume. As you compromise stroke volume, you're going to compromise flow. As you compromise flow, you're going to get end-organ perfusion, so this person may very well not be making much urine, as just an example of one possible. So they've got to be run relatively euvolemic. In fact, they tend to do a little bit better on the slightly full side, the upper end of the range. If you're going to err, you want to err to a little bit more full in this population. What do you do with heart rate and afterload? So in this group, you want them normal to slow. You want enough time for them to get adequate filling. Too slow is a problem. All that blood longer diastolic time, all that extra blood trying to get into a tight ventricle. And afterload doesn't matter really, right? Those guys can pick up. You want to put another weight on that barbell, go for it. I'll move it. That's okay. You can do that. So acutely, they don't really care much about afterload. Chronically, and at least the hypertensive ones, if you keep their afterload low, you keep away that pressure resistance issue, you'll stop the hypertrophy, at least you have a chance. You might actually see some regression of that hypertrophy. So chronically, that works. Acutely, not much difference. So maintain your preload. Remember that inotropes or your endogenous catecholamines, that stress response, they may be on their own epinephrine drip from their own body, is going to do what? It's going to stiffen that ventricle even more. So the group of these patients who have this in their severest form need help. They need something to help their heart relax. The two categories of that are the beta blockers and the calcium channel blockers, because they not only are negative inotropes in terms of squeeze, they actually are positive lusitropes. They allow relaxation. Just to remind you, chronotropy rate, inotropy squeeze, lusitropy relaxation, and dromotropy, conduction. That's so negative dromotropes block the AV node. In this case, what you want is positive lusitropy, okay? So let's shift to the side that's easier, and then we'll wrap up. The dilated heart, big heart on chest x-ray. Here's that normal curve. The curve moves. Now you have higher volumes at higher pressures. The differential diagnosing this, maybe your PMI has moved, but again, it principally comes back to chest x-ray, clinical history, and echo to see a dilated ventricle. These sorts of things lead to this problem. Again, you've got those slides earlier that show you all of the complete differential. It leads us back to this conceptual table. So now what's going to happen if the ventricle's bigger at the end of diastole? So now the EDV should be higher, right? You leave more blood in the ventricle at the end, but what you did was eject the same amount if you're compensated. So now look again. Identical cardiac outputs in 3 separate conditions with 3 completely different ejection fractions. I hope this drives home this disconnect between EF and cardiac output and gets you to really start thinking that when the EF is abnormal, notice the stroke volume, if the heart has had any chance to compensate, is the same. So what's really different? What is the EF actually telling you most of the time? It's actually telling you what EDV is, right? When the ejection fraction is elevated, most of the time the EDV is small, meaning the heart is hypertrophied. And the EF is low, most of the time it's telling you the denominator is normal. The denominator is big, it's telling you that the heart is dilated, okay? Telling you less about the function and more about the condition that the heart finds itself in. So how about treatment? I think this one's reasonably straightforward, but might surprise some of you. So you've got to keep heart rate slightly elevated here. They can't squeeze already at baseline. They have this difficulty in squeezing. So if you make the resistance of the system go up, the ventricle actually fails worse, okay? So that's not a good idea. So these all need afterload reduction. And I put euvolemia here because that's actually true again, okay? So they're barely able to squeeze. They're starting at that big EDV to keep stroke volume normal. If you make their volume reduce, they can't squeeze a higher percentage. They don't have that ability. So what happens? Stroke volume falls off, cardiac output falls off, perfusion gets worse. So where the preload, the diastolic patient needs to be euvolemic and slightly on the high side, this group is euvolemic, maybe 5% on the dry side in the perioperative period. I'm not talking about taking a colon to the OR and giving them 500 cc's of fluid for the whole case, something we frequently still see people do in this patients of systolic dysfunction, thinking you're helping them by running them that bone dry. You're actually complicating their care. You might squeeze through the operating room, but for that hospitalization. But you're going to keep them on the dry side of euvolemia. So I think this summarizes that. Inotropes they may need for squeeze, they might need vasodilators, and we all have to accept blood pressures in the severest of this population that are quite low. I want to point out there are 3 phases or 3 conditions: the totally compensated at the top, the completely uncompensated at the bottom. So how can you tell? You got clinical findings and you know, their creatinine, their feet warm, do they have hair on their anterior shin, these sorts of things. But you also know, because look at that first group, blood pressure is pretty normal. They can't get blood pressure normal in the bottom group because they don't have enough squeeze, so it's not by force, and they can't get pressure normal by resistance because we already said if resistance goes up, the ventricle fails even worse. So if they're getting a relatively normal blood pressure at a relatively normal heart rate, they're darn well compensated. If they can't generate pressure and they're already using heart rate sitting around at baseline, they're telling you they're all the way completely uncompensated and in trouble. And so one of these patients might need lots of invasive monitoring. Another one of these patients for the same surgical procedure might need much less, even though they both carry the same diagnosis of dilated cardiomyopathy. So this is the clinical relevance that's important. Lots of findings that you might have to summarize there. Intraoperatively, again, that diastolic patient needs some way of giving volume, could be CVP or peripheral IVs. The systolic dysfunction, you don't know when they're hypotensive as to whether that's volume or the agents that we use that can suppress inotropy, so you need more data. But postoperatively, at least in that first 24 hours, they're almost reverse. The diastolic person is now on an epinephrine drip and has difficulty relaxating, and so you might very well need additional info. The systolic person is on their own epi drip, and most of the time it's hypovolemia in the immediate perioperative period. With that as background, can you guess what went wrong in this case? And what they missed really here was identifying that how often have you found somebody tell you that the blood pressure is elevated when it isn't, right? We see low blood pressures, but somebody didn't blow the cuff up enough. How often does somebody dictate a wrong number in a chart? Not more frequently than we would like. And so it turned out this person's EF is actually wrong here, and you should have been able to think about that being wrong, because if they had some dilated heart and some problem with squeeze, they shouldn't have been able to generate that blood pressure, okay? And so somebody should have paused instead of intervening and gone and checked. So this patient was managed as a systolic dysfunction. When they had diastolic dysfunction, they couldn't relax. They gave them almost no fluid. They put them on high-dose epinephrine, and they got no response to that, so ended up with an acidotic, lactemic, oliguric, mottled patient that the family said, enough is enough. We said we don't think so. Let's get a stat echo. While we're waiting, let's give 2 liters of fluid. After we got the echo and confirmed that that was not correct, and gave another 2 liters of fluid within a number of hours, off of the epi, awake, alert, completely perfused, not acidotic, lactate gone, following commands, extubated. Family comes in the morning and the lady is sitting in a chair eating breakfast. So CHF is a grab bag. I hope you now will never say CHF again. I hope you'll say I have a patient with reduced function CHF or preserved function CHF or diastolic associated CHF or systolic associated, because their outcomes are different and their management is different. And I hope you have a better understanding of that physiology and how it ties to treatment.